aspects, but troponins are found in the cytosol regardless, about 3 to 4% of the wet weight of the myocardium. And then the rest is found in the sarcomere and the cardiac contractile apparatus. Upon myocardial injury, so there are those two words that I said already once, and I want you to remember this: myocardial injury. I did not put myocardial infarction there. Upon onset of myocardial injury, two things happen. The first is that the cytosolic troponin rapidly exits the cardiomyocyte. And this is what explains the rapid rise in troponin that is now detectable within minutes with a high sensitivity assay, after which the cardiac contractile apparatus begins to lose troponin in a more delayed fashion, which is why you see the gradual rise and then persistent concentration in the bloodstream. Now, folks, this is a characteristic phenomenon of the COVID era, which is that I'm on clinical service and I just got paged. So I'm going, this is the cath lab, so I must answer this, but I promise you I'll be back within 30 seconds. So please forgive me. I'll be back in just one moment. And of course, I'm terribly sorry about this.
Not to worry, not to worry. We are all on service as well. Can I request everyone to stop their video so that we can focus on Dr. Januzzi, please? Jim, you're sharing the screen, just so you're aware.
Okay, I'm back.
Yeah, you were sharing your screen all the time.
Oh, yeah, goodness. Okay, well, you got to see the situation of what I was dealing with. Sorry about that. Yeah, I thought I had flipped it over to the other screen, but in any event, well, hopefully no one thinks that I should fix that. So high sensitivity troponins. So this is really important to remember now that we've returned to this, which is this early rise and delayed presence really determines why troponins are so good at what they are good for, which is detection of injury. But now that we've got high sensitivity troponins, we can see things that we hadn't previously been able to see. So why is that? Well, the first is that about, well, now 21 years ago, geez, The Myocardial Infarction Redefinition Task Force affirmed that troponin would be the preferred biomarker for the diagnosis of myocardial infarction. But over the last 21 years, we've really sort of evolved the definition quite substantially and have made the argument that a myocardial infarction is not only defined biochemically by troponin, but very importantly must have corroboration with other factors besides an abnormal myocardial injury marker. And to some extent, that's driven by the recognition that biomarkers alone cannot and should not replace a clinical syndrome like a myocardial infarction. So the universal definition most recently was updated with two important points. One is the use of troponin with at least one value rise and or fall around the 99th percentile, and I'll go into what that means in a second, together with symptoms, ECG changes, evidence for loss of function. And this one's really important because, you know, we're depending more and more on imaging to help support our decision-making about myocardial infarction, as well as if we go to cath, like the one that I unfortunately showed to you all, I'm sorry about that, as well as postmortem evidence to support the clinical judgment that is triggered by the recognition of an abnormal troponin. In addition, in the universal definition, we have what we refer to as a universal classification of MI, of which the most common two forms that we deal with are type 1, which is the plaque rupture and ischemic myocardial necrosis, and type 2 MI. And I'm going to talk more about type 2 MI in a little bit because this one's very common in the intensive care unit, which is the so-called supply-demand mismatch. You may not know, but in fact, there are three other types of MI. There's type 3, which is an MI that occurs without troponins being drawn, actually. These are patients who roll in with ST elevation and then have a cardiac arrest or some other factor that identifies the presence of a myocardial infarction. Procedural MIs, not uncommon at all, secondary to PCI, stent thrombosis, or restenosis. And then, of course, one that we don't talk much about because it remains somewhat poorly defined is CABG-related MI. Turns out myocardial injury is very, very common in patients that go through bypass surgery. And so how we identify MI in these patients is fraught with challenges. Now, I said that I'd come back to the 99th percentile, and indeed, in the third universal definition, we put our money down saying that an MI should be defined as myocardial injury as detected by a rise and or fall of troponin with at least one value above the 99th percentile. So there's a lot there, but what basically we said was acute myocardial injury. You can't just have an abnormal troponin that hovers, and we'll talk about what that means in a little bit, but you really need to see a rise and or fall that crosses that 99th percentile. And you can say, well, geez, I mean, why didn't we use that cutoff with our older versions of the troponin? And it turns out that we weren't able to measure with acceptable precision, or coefficient of variation is what us lab people say. We weren't able to measure with good precision at that very low concentration with a conventional assay. Whereas with a high sensitivity assay, we now can. And there's all sorts of reasons how the assay was made high sensitive. But the point is that these assays differ. The previous troponin you used until not that long ago versus the high sensitivity assay, the differences are like the difference between a confocal microscope and an electron micrograph, right? They're dramatically different in terms of their ability to see things at the very small concentrations. So this is what we see with a high sensitivity assay among normal individuals and blood donors. It turns out that a lot of people have a measurable number now. So this concept of troponin positive is something that we're really trying to move away from, because pretty much everyone has a number. Whereas previously, you know, short of a relatively large amount of myocardial injury, you wouldn't expect to see measurable troponin. Here, now with a high sensitivity assay, you know, up to 75% or even more will have a measurable troponin. And so when we thought about what abnormal was, we came down on this recommendation of using the 99th percentile. So the 99th percentile basically says, as the name would imply, 99 out of 100 individuals with no structural heart disease, no risk factors, basically normals, will have a value below this cutoff. And you can see here, this is high sensitivity troponin T. The 99th percentile is way lower than what the old upper reference limit for this assay is. So when you look at how much lower this threshold is, it should come as no surprise that we detect much, much more injury, whether it's acute or chronic, when we shift to a high sensitivity assay. And people say, okay, well, you know, my patients in the ICU or my patients in the emergency department are not normal in the sense that, you know, they're not healthy individuals with no medical problems. And that's very true. When you look at what determines high sensitivity troponin in those without an acute MI, it's everything you would expect. If you're older, you've accumulated structural heart disease that may not even be identified yet. Men have more myocardial mass. Black individuals have higher troponins at baseline. The presence of chronic kidney disease, diabetes, hypertension, and of course, underlying structural heart disease will determine higher values in the absence of an acute MI. So once again, when we come back to this question of what does an elevated troponin mean, it does not mean myocardial infarction anymore. When troponin was a lousy assay, it was a great test because it was sensitive, better than CKMB, more specific than CKMB, but it wasn't as sensitive as it could be. So when things were abnormal with the previous troponin assay, it was mainly a myocardial infarction. But now with high sensitivity assays, we can detect all of this injury that occurs related to underlying structural heart disease and other risk factors that we were not able to recognize previously. Now, you already know this, having shifted over to high sensitivity assays, because the assays have changed their label from nanograms per milliliter to nanograms per liter, you will now detect, the numbers that you see are larger, but nothing has really changed, right? You've converted to nanograms per liter, but the numbers themselves are the same. But it's amazing to me how much this bothers people when they convert to high sensitivity troponin. So a high sensitivity troponin I of 10 is now 10,000, right? And that really freaks people out when they see that. As I've already said, you'll pick up more people with myocardial injury, of which most will not have an MI now. And we'll talk about troubleshooting in a bit. But on the plus side, you'll be able to detect myocardial injury much faster. And that really, I can skip this because I just made this point already. That helps you to think about how these tests might be used compared to with a previous troponin. So from the onset of symptoms, it was shown more than 10 years ago now in early studies of high sensitivity assays that the high sensitivity methods were abnormal way faster than conventional methods. So all of these colored lines are sensitive and high sensitivity assays, whereas the black line is a conventional assay that we used at MGH until just a couple of years ago, and many institutions still use, right? You know, around the country, many places have not yet gone to high sensitivity. So what you can appreciate is that the area under the ROC, which is a way of expressing sensitivity and specificity, was essentially almost as high at 2 hours or less than 2 hours as it was if you waited a bit longer, really indicating that these assays become abnormal very quickly. And this has led to the development of protocols that are accelerated. So we've adopted at Mass General the ESC 1 hour protocol, which essentially says we get a baseline and a 1 hour, and then follow what the pathway here says, which is, you know, if it's very low at baseline and doesn't change much, you've ruled out. And that's really where the money is, quite frankly. If it's elevated or rises, you're in what's called the rule-in zone, but it does not mean that you've got an MI. It means you've got injury. And then there are patients that fall in the middle, and we frequently use CTA and other tools in those individuals who have ambiguous values or values that are hovering but are not grossly abnormal. In addition, to fine-tune the approach, many have adopted a sex-based approach for the cutoffs. And this speaks to the fact, as I've already said, that men have higher values for troponins than women. Stated another way, women have lower values. And the reason why this is important is if you set your cutoff at the same place for both men and women, you'll detect more injury in men because the cutoff is too low, and you'll detect less injury in women because it's too high. So this has led to the development of sex-based cutoffs to maximize sensitivity for both. And by the way, this is not a new thing. It was also seen with CKMB, but we never used sex-specific cutoffs with CKMB previously. So sex-based cutoffs have been recommended and are widely adopted, although not every individual site has used them. So, you know, the early data from Europe suggested, and it's kind of embarrassing to say, but high sensitivity assays have been in use now for over 10 years in Europe. The European experience, and this is just one example, shows, again, great rule out capability, shortening ED length of stay with a very low miss rate for acute myocardial infarction. And that, you know, led to a lot of enthusiasm. And indeed, we converted to high sensitivity troponin about 2 years ago now, a bit more than that, in fact, with the algorithm that I show here. And, you know, it sounds rosy, I know, like it's been in use for 10 years and, you know, in Europe, and people think it works great. But, you know, there are potential risks, right? So, excuse me, we have a more refined assay. It's faster. You can detect more injury. And what could possibly go wrong? Well, the issue is you need to think and put your thinking caps on when high sensitivity troponin detects injury. So compared to a conventional assay seen here, the presence of injury, the red circle, was largely driven by the presence of coronary ischemia because the sensitivity of the assay was unable to detect the prevalent injury that occurs from other non-coronary causes. However, with a high sensitivity assay, you pick up proportionally more ischemic injury. About 25 to 30% of patients previously called unstable angina are now called an MI. But you then also pick up non-coronary cardiac necrosis, which increases substantially. You pick up a lot more injury. And so this has led some people to be predictably uncomfortable, particularly because the testing patterns in the United States for troponin are very different than in Europe. The European strategy is for a physician to evaluate and then order, whereas typically most institutions have a protocol where the troponin is ordered essentially for, and I don't mean to joke about it, but essentially for any symptom between the nose and the belly button. And really the pretest probability therefore is much lower. So if you look at you know, cardiac studies from the United States, from the ED especially, the MI rate among studies looking at troponin in the United States is only about anywhere between 2.5% to 5% and no more. So we test a lot of people who don't have an acute coronary syndrome. And the obvious concern is if we're detecting injury more frequently, everyone's going to need a consult, everyone's going to get a cath, and we're going to harm people. And we understand that. But in fact, when you look at, in fact, what has happened in the United States in institutions that have gone live with a careful and logical rollout like we did at MGH, what we found, in fact, was that, yes, in fact, among over 150,000 individual patients, and this paper actually has been published by now, there was a slight increase in what we refer to as cascade events, multiple tests. But what we found was, in fact, that patients evaluated with high sensitivity troponin actually received fewer stress tests, fewer caths, fewer cardiology consults, and fewer admissions. So what drove the increasing so-called cascade events? It was just more troponins being measured and more EKGs, which is part of the algorithm, if you remember. You get a baseline 1 hour. And then what we do at MGH is if we are uncertain, we'll get another one at 3 hours. So that would be completely expected and really illustrates exactly the potential benefits from higher sensitivity, particularly at the point of care when you're first evaluating patients. Now, there are important nuances that you need to understand about troponins in general. Now, with increased sensitivity, one of the concerns we have is that we'll become less acutely aware of what I refer to as the so-called true false positive. So Kian McCarthy from our group has really focused on troponin, optimizing troponins, and their interpretation. And he wrote a nice editorial in JACC not long ago, focusing on when clinicians should have a heightened awareness for when an abnormal troponin may actually be truly elevated or falsely elevated due to an analytical issue. It turns out that a false elevation in troponin is rare, but may occur. And probably the most common situation that causes a falsely elevated troponin is chronic skeletal myopathy, which affects troponin T in particular. The other, which involves both troponin I and T, are the presence of heterophile antibodies after atypical respiratory illnesses. So that's important to remember, although to be very honest with you, quite rare. But it gets to the issue of how do you manage when a patient has myocardial injury? You've been called to see a patient with an abnormal, even acutely rising troponin, and you just in your heart of hearts, much like the cath that I unfortunately showed everyone, in a patient with an abnormal troponin, does not have an acute myocardial infarction. So there are a few things that we teach our clinicians to recalibrate what we should think when we see a myocardial injury state manifested by acute myocardial, acute troponin elevation. The first is it's important not to minimize the importance of myocardial injury. You know, on the one hand, while it may cause confusion if it's not an MI, what you don't want to do is downplay the prognostic meaning of injury. So we really try to, minimize expressions like troponin positive, troponinemia, troponin leak, because these patients have a measurable risk now. And, often you can identify, and I'll get to the differential diagnosis in a second, but you can, often identify the reason why they have myocardial injury. But importantly, when you're thinking about it relative to the myocardial infarction diagnosis, it's all about pretest probability. The Bayes theorem dictates that pretest probability dominates the validity of a post-test result. So if someone has a 0% likelihood for an acute coronary syndrome and their troponin is elevated, most likely it's related to some other factor that caused myocardial injury. And therefore, when you think about any diagnostic test that we use, and this includes tests that are used to evaluate patients in the ICU setting, remember that troponin elevation, acute injury, identifies the presence of injury, but not the mechanism. And so remembering that there is a differential diagnosis for abnormal results of any lab test that we run, more than ever now with a refined troponin assay, it's important to remember the differential diagnosis for acute myocardial injury. Now, importantly, serial measurement is your friend here. If you see elevated values that are sort of changing, but not really, measuring it, more than just at baseline of 1 hour will help reveal whether this is really a chronic injury state or an acute injury state if you see a substantial rise and/or fall. Furthermore, as I said, moving away from the concept of the so-called troponin positive patient, think about how positive they are. Because when you look at the positive predictive value of troponin, particularly in those individuals with a rising troponin concentration, the higher you get on the y-axis, the higher the positive predictive value for myocardial infarction gets. Now, of course, if you see people in the ICU setting that are critically ill, you're going to see values that are pretty high in the absence of an acute myocardial infarction. But short of the other tools that we use in this setting to confirm or refute MI, it is often quite logical to apply the recognition of things like acute viral illnesses, influenza, cardiomyopathy, hypovolemic or septic shock. All can cause acute injury to a fairly substantial degree, and without evidence for ischemia on EKG, as well as point of care ultrasound, which we use very heavily in our ICU now in this setting. It's hard to identify MI without corroborative evidence. Now, for you all, for us, the biggest challenges that we run into are the diagnoses that I've got highlighted in red here. And type 2 MI is a common and really challenging diagnosis for a couple of reasons. The first is, you'd be very surprised to know, although based on what I've said already during this talk, you might not be that surprised, that it's actually often misdiagnosed. And again, Kian McCarthy from our group has spent a lot of time focusing on trying to refine correct diagnosis of type 2 MI. And in our own institution, there were several hundred cases in the year 2018 that were coded as a type 2 MI that actually nearly half did not meet the criteria. And if you look at why they were called a type 2, it's because they had injury. They had, an abnormal troponin, and people said, it's probably a type 2 MI. That's not correct, actually. And you cannot and should not call a myocardial infarction absent the presence of the other variables in the universal definition. Now, in your heart of hearts, if you think that somebody after an episode of AFib with rapid ventricular response, but who didn't have any of these other features, had a type 2 MI, of course, if the clinical picture makes sense. But a lot of these cases were patients who came in with pneumonia and myocardial injury, but no other signs or symptoms and no corroborative evidence. So it's important to be cautious, because type 2 MI gets grouped in bundled payments and gets characterized in the hospital readmission reduction program as an MI. But as you all know, type 2 MI lacks a therapeutic indication. And so these patients often get readmitted and have bad outcomes. And that's something you want to try to avoid if inappropriately applied. The other reason why type 2 MI is a real problem is that it's not a benign diagnosis. So Hannah Gagan in our group has shown quite convincingly, and Kian has in subsequent studies, that type 2 MI has a very similar risk as a type 1 MI. And they're actually at risk for multiple events, including heart failure and other cardiovascular complications, such that when a patient has a type 2 MI, their risk is quite substantial. Now, we're trying very hard to figure out a treatment strategy for individuals with type 2 MI. And presently, we really don't know from a medical perspective. Of course, we're going to do the things we do for MI. From a medical perspective, treating the trigger, suppressing AFib, treating GI bleeding, antipyretics, other things to try to reduce the supply-demand imbalance is important. But the big question, of course, is, should we revascularize these patients? And we don't know, although there are tempting data now coming out suggesting that revascularization may in fact reduce the long-term risk associated with type 2 MI. Now, what about heart failure? I'm sure you see a lot of heart failure in your ICU, as we do. And certainly troponin elevation is prevalent among patients with acute heart failure. I'll remind everyone that troponins, more than ever, are not a myocardial infarction marker, particularly when you see just how frequently they're elevated in individuals with heart failure. And in fact, in acute heart failure, nearly everyone has measurable troponin, and a substantial percentage have a rise and or fall around the 99th percentile, even if a patient is non-ischemic. And people might be tempted to say, it's a useless biomarker. Why are we measuring it in this setting? And I'll remind you all that there are guideline recommendations to measure troponins in acute heart failure, of course, to identify acute myocardial infarction as the cause of MI. But in addition, concentrations of troponin are dramatically associated with prognosis in heart failure. These are data looking at ambulatory heart failure from the VALHEF study. And there have been one study after another showing that elevated high sensitivity troponins above the 99th percentile, basically, are associated in a linear fashion with the risk for mortality. And what are these markers telling us? Well, if you take a step back and ask yourself, what is the most likely trigger for troponin besides myocardial infarction? It's underlying wall stress with injury and subsequent remodeling. And indeed, we recently showed in a study that was just published in Circulation Heart Failure that concentrations of high sensitivity troponin, particularly when in concert with an elevated NT-proBNP, were associated with the largest amount of loss of ejection fraction in patients with chronic heart failure. And you know what? It stands to reason. If you take a step back and think about, if you've got only so much troponin in your heart muscle, and you're developing constant injury and constant release of troponin, it stands to reason that it's going to translate to worsening left ventricular function. What about an all too common scenario, which is the complex intersection between kidney disease, heart disease, and troponins? It is well recognized that kidney failure is a prime reason for abnormal troponin results. And this speaks to two separate issues. One is that, of course, patients with chronic kidney disease have a substantial overlap of risk factors and prevalence of structural heart disease. But it gets even more complicated because CKD itself leads to myocyte injury. Again, myocardial injury and CKD, particularly at advanced stages. I mean, think about the milieu of an end-stage kidney disease patient. What is healthy about the circulating compounds in somebody with end-stage kidney disease who is unable to clear the toxins renally? And so CKD itself, in a linear fashion, is associated with myocyte injury. There's a big misperception that troponin is entirely cleared by the kidneys. It is not. In fact, a small amount is. You can find it in urine, but it is a small molecule. Therefore, until you get down to end stage, most of the measurable troponin circulating in patients with chronic kidney disease is from release and not from impaired clearance. And in fact, you can see, for example, individuals on dialysis, young people in particular, who develop end-stage kidney failure from glomerulonephritis, for example, who have unmeasurable troponin. So if it was just related to clearance, these kids and these young adults would have marked elevation of troponin. So it is a release phenomenon from most individuals. And yes, very prognostic. It's not a good thing to have an abnormal troponin in most situations. And it's been shown again and again that in chronic kidney disease, it's prognostic. But you know what? That doesn't help us clinically at the bedside when you're called urgently to see a patient. So what do we know? Well, the first is that the negative predictive value is preserved. So stated another way, if a person has had chest discomfort for a long period of time, their ECG is reassuring, and the troponin is frankly negative in well-timed samples, that really is reassuring and helps to exclude acute myocardial infarction as the cause. On the other hand, more often what we see is abnormal, but without any change when you get to high sensitivity measurements. And we recognize that the optimal cutoffs are probably higher, somewhere in the range of 5 to 10-fold higher with high sensitivity assays. And as my slide says, that's not actually very much when you think about just how low in the normal range we're measuring now. So what we do is we look at the results. We expect to see some amount of injury and expect chronic injury. If there's no change, that's chronic injury and more likely than not unrelated to an acute presentation. So looking for the delta is important, particularly since patients with CKD, when they have an acute injury state, usually have a big rise in their troponin. So serial measurements over a baseline 1, baseline 2, even at baseline 1, 2, and 3, to look for large deltas is really important. How much of a change also is important to discuss. In most cases, the delta in a patient with an acute myocardial infarction is quite large. We use a threshold change of somewhere between 7 to 10 nanograms per liter with high sensitivity troponin T. In individuals with CKD, in addition to higher cutoffs, the delta is typically huge when they have an MI, so it's often not subtle. Also, I remind you that you don't even need a troponin in somebody with CKD with chest pain. Clinical judgment is really the most important factor here, because really, if you think about it, if somebody's got a believable story for myocardial ischemia from an historical perspective, What do you think is going on in somebody with chronic kidney disease? It's heart disease, and heart disease until proven otherwise. Now, shifting a bit more to respiratory illnesses and to the ICU setting, I need not remind any of you, and as a renegade New Yorker, I watched with horror last March as New York got hit with the first wave of coronavirus infection. We were soon to follow up in Boston. And boy, did we get a whole heap load of experience with respect to management of individuals with COVID-19 pneumonia and acute myocardial injury. And I'll remind you that, and there's been a lot of evolution and understanding about the myocardial injury in COVID-19, which is due to at least two mechanisms, and certainly more probably. One is there's direct myocardial injury from invasion of the myocardium related to the fact that the ACE2 receptor is one of the places where the SARS-CoV-2 binds to and invades the respiratory and other epithelial cells in the body. And there's ACE2 in the heart. So via invasion to the myocardium, and we can recover SARS-CoV-2 particles in myocardial tissue in certain circumstances, it is theorized that this may lead to either injury or frank inflammation. And indeed, there's a broad differential diagnosis for the potential mechanisms for acute effects of viral infections on the cardiovascular system. But here's the key, and I really want to make this point very loud and clear. As I'll show you in a couple of slides, when this started to get recognized, I wasn't surprised at all, because anyone that works in the ICU setting who's cared for patients with severe influenza, for example, needing to be intubated, needing to be on ECMO, you see this in every one of those patients, which is inflammatory changes that may cause myocardial infarction. We've seen it, secondary MIs being triggered. Myocardial inflammation from myocarditis or just from injury, from cytokine-mediated injury. And then, of course, triggering of arrhythmias in vulnerable individuals. So while, certainly there was a lot of fear around COVID-19, around SARS-CoV-2 being maybe somewhat more cardiotrophic, and it may be, importantly, a lot of what I'm saying to you here goes for any patient with ARDS, any patient with acute severe viral illness, because often these viruses have very similar behavior. So how do we translate the myocardial injury seen in COVID-19 to maybe something actionable? The first thing is you have to think about, much like in all of the other slides I showed you, what is the absolute value? In other words, how much injury do you see? Because it turns out that the range of association between myocardial injury, is essentially linear with the severity of the disease. So these were, until about 6 months ago, all of the troponin studies that were published, and we summarize these in a review article in JACC, showing that essentially, depending on the severity, the frequency of troponin abnormalities, is not 100%. It's quite linear. And, so when you start seeing patients in the ICU setting, it's 1 in 5, then it goes up to 1 in 3, 1 in 4, 1 in 2, and then, in some studies up to 100% in the critically ill ECMO-based analyses of troponin. So depending on the setting is really the more important piece. And people have asked, can you predict disease progression by measuring troponin in individuals who are on the floor with non-severe COVID? And the answer is no. It actually appears that it is really an epiphenomenon of the severity of the disease rather than something sinister brewing in the background that then comes to light prior to the patient decompensating and needing the ICU. And as I've said, everything old is new again. These are data from 15 years ago and older now, looking at troponins, looking at natriuretic peptides. The troponin data on the left are high sensitivity troponin. We were playing with a high sensitivity assay around 12 years ago with a sponsor, and we measured them in the FACT study, the fluid and catheter treatment trial, showing that among ARDS individuals, up to 100% have measurable values when you get up to the highest quintile. N-terminal proBNP, same issue. You see heart failure-like concentrations in patients who have no heart failure, but who have severe myocardial inflammation and dysfunction related to their critical illness. So how do we summarize all this? Well, we know that cardiac complications are common in folks who have COVID-19 and other severe respiratory illnesses, including ARDS. And this injury associated with these diagnoses is quite prognostic. So the way we synthesize it is we think about the differential diagnosis for the cause. I would say the great majority of patients that we see with ARDS, with COVID-19, with influenza and other respiratory illnesses causing abnormal troponins are related to injury without a defined myocardial diagnosis, like a type 1 MI, or even a type 2. But it's important to keep them on the differential diagnosis, because when you look at the outcomes of individuals with cardiovascular disease, there's no question that the presence of underlying coronary artery disease is a not to be missed phenomenon among individuals with COVID-19 and other diagnoses that we see in the ICU setting. So, when we think about the mortality rate and we think about the management for these folks, it's worthwhile integrating the background medical history of these individuals, integrating the abnormality of troponin in order to be able to predict trajectory. And it really largely, and these are data from China, some of the earliest data from some of the earliest case series in COVID-19, it really seemed that most of the adverse outcome fell in individuals with a background history of cardiovascular disease, and in particular among those individuals with marked elevations. So while at the lower range, you see COVID-19 myocardial injury, when you start getting to factors of 5 to 10-fold above the upper reference limit with high sensitivity troponin, together with underlying structural heart disease like cardiovascular, like coronary artery disease, those are the patients that we start taking a closer look at. So what we do in our intensive care unit setting is use the standard tools, history, physical, the usual lab tests, radiographic imaging, and EKG. That gives us the universal definition of MI. But what is now which is now much more widely available and is dramatically supplemented our integration of high sensitivity assays in the unit setting, is I think the crucial role of point of care ultrasound to support our decision making regarding next steps, including cardiovascular consultation, cardiac MRI, CT angiography, or even invasive angiography. And this isn't just a COVID-19 specific thing. This is how we approach it, generally speaking. So if there's one takeaway besides the myocardial injury piece, remembering that this test is really just telling us about myocardial injury, and really you need to roll everything together in your standard evaluation, is the rising and critically important role of point of care ultrasound. And we published, again, another paper in JACC that was focused on COVID-19, but really, you could swap that diagnosis out and swap pretty much any critical illness diagnosis in regarding the role of advanced imaging in the ICU setting, where the recommendation was essentially to lean heavily on these 5 tools as much as possible. So I'm going to stop there and take some questions. But before I do so, you were there for the beginning of this case. I've now been paged by the cath lab a second time, and I'm going to answer that so I can at least get the final outcome of this cath, and then we have time for questions. So thanks very much for the opportunity to come back yet again, and I'm sorry about the cath lab calling. It's unfortunately a true phenomenon of the modern COVID era that we're trying to juggle 20 things all at once. Thank you so much. I'll be back in just 1 second.
An occupational hazard for a very busy cardiac intensivist. Thank you very much, Dr. Januzzi, for this very comprehensive review of our new high sensitivity troponin, ranging all the way from the description of its structural biology to practical application. anyone who wants to ask questions could put it in the chat box so we can ask him when he's off. Oh, there he is. So maybe I'll kick it off, Jim. You talked about how, in fact, you found a decrease in what you called cascade events at Mass General since you started using high sensitivity troponin. My concern is what is happening across the country. Is this true everywhere? Is this true by and large, or is this true mostly for, academic institutions that are so focused on really analyzing this in great depth?
Sure. So, it's still kind of early to answer that question with any definitive sense. However, another academic medical center, the Mayo Clinic, published their experience not at the home clinic, but actually at an affiliated hospital. So not the academic Mayo Clinic Center, with 2,000 patients, not 150,000. And they had the same results we did. Furthermore, it's really critically important to remember you don't see what you don't see. You don't know what you don't see. And a lot of the patients that are now getting discharged with high sensitivity assays might have been previously admitted. So part of it is that you're shifting numerator and denominator somewhat. And it's going to be a challenge to really say that that it increases utilization. What it does is it shifts the kind of patients we're seeing, to be sure. But, we actually were not all that surprised when we saw the results from our place, because, our docs in the ED were saying, look, we're sending a lot of people home. The ones that we're calling you about, we might not have called you about before, but they've got a lot of injury and we're just trying to figure it out. And that's where we're really developing a cardiac CT program around and trying to identify individuals with injury who are safe enough to be sent home.
Right.
Such that, and there was just an editorial in Jack yesterday about this and a paper in Jack about it. But with some form of cardiac follow-up so that we don't ignore their injury, but we don't admit them for a needless rule at MI.
Interesting. One question, I think, which is probably going to be the last question, is from a very experienced clinician, and she asks, is it clear that it is still a clinical decision using troponin as to who needs to be cathed for stent or cabbage?
I absolutely, completely agree. Completely agree. It is, more than ever. And this is we got spoiled when troponins were a lousy assay, because basically they were better than CK&B, but what we didn't realize was that it could have been a lot better than what it was. So when troponin was abnormal, it was most likely an MI. The problem was we sat around twiddling our thumbs for 6 to 18 hours, 24 hours, waiting for the test to become abnormal. Now that we can detect it becoming abnormal early, we're also seeing a lot of non-ischemic injury. And that's where it really, really matters to integrate your clinical judgment. One very important point to emphasize is that once it's frankly elevated, troponins, whether high sensitivity or conventional, tell you pretty much the same thing. So in other words, it's really that low level period when it's rising rapidly where the greatest advantage of high sensitivity assays are seen. It's a challenge, to be sure. What I see is that places that really struggle with high sensitivity assays are when they just launch them without any education and without forewarning, because it is just such a different way of approaching the testing of individuals with suspected ACS.
Perfect. Thank you so much. This was a very useful, very helpful talk. Often we have talks that are academically very robust, but this one is not only that, but also very, very practical for us folks in cardiology, critical care, and the ED and internal medicine. So on behalf of my audience, thank you very much. We're going to have you back.
Thank you. I'd love to come and visit.
Yeah, I remember Terence Cardinal Cook was of Flower on Fifth was
Flower Fifth Avenue. Yeah, I was born
right.
at Flower Fifth Avenue. Yeah.
It was the founding hospital for New York Medical College.
Where I went to medical school. My father was actually working in the ICU at St. Vincent's Hospital, where he was a resident when my mom went into labor. And he was covered that night by Ned Wayman, who is a cardiologist here now at Mass General, who wrote the textbook on echo. So Ned covered for my dad. I was born at Flower Fifth Avenue. I went to New York Med. Believe me, my heart is in New York. So, you know, I miss the city. We're going to be, actually, I'm on call this weekend. We're coming down next weekend for the first time in 2 years for a visit. So looking very much forward to it.
Yeah, we'll catch up. We come look us up. We're going to have you back on this same screen. Thank you so much.
Good to see you all. Take care.
Thank you.